Chapter 44, The Child with GU Alteration Continued. Acute post-streptococcal glomerulonephritis occurs as an immune reaction to a group A beta hemolytic streptococcal infection of the throat or skin. Hematuria is a classic sign and can vary from very little blood to a gross amount of blood. The more blood in the urine, the more smoky or tea-colored it is. Edema, which is worse in the morning, is another sign. The edema is mainly in the eyelids and the ankles. You can see a decrease in urinary output as well. Hypertension can occur and can be severe due to the kidneys having ineffective infiltration and an increase in the water, sodium, and the waste retention. They may have a fever and become fatigued. Pulmonary edema is a life-threatening complication. History, symptoms, our labs are used to diagnose. The labs will include the UA, which will reveal that hematuria with RBC cast that indicate the glomerular injury. Proteinuria is also present, but not in high levels. If the infection is severe, their BUN and creatinine are elevated. High potassium and low bicarb levels can be noted as well. WBCs are normal and mild anemia can be noted. The ASO titer indicates the presence of antibodies to the streptococcal bacteria. If the child has acute renal failure, they will need to be hospitalized to help with the fluid and electrolyte imbalance. Antibiotics will be needed. Antihypertensive meds may be needed, and reducing salt and water intake and use of diuretics. The effects are usually self-limiting, and once they start diuresis, they are showing signs that they are improving. Most lab values are back to normal within 6 to 12 weeks, but it can take up to 2 years for their microscopic hematuria to be resolved. Nursing care during this acute phase includes careful monitoring of the eyes and nose, accurate daily weights, administering the antihypertensives, and antibiotics if ordered. They may need to be on fluid restrictions, so if they are, teaching about that and monitoring carefully. They need periods of rest to get better. Allowing for this can be by clustering your care, or allowing periods of rest between activities can help. Maintaining proper nutrition can be challenging if on a low-sodium diet. Keeping parents up to date on the treatment plan and include them in the care is needed as well. Provide emotional support. Nephrotic syndrome refers to the kidney disorder characterized by proteinuria, hypoalbuminemia, and edema. There are 2 types, and we will focus on primary nephrotic syndrome, also known as minimal change nephrotic syndrome. Most times, the cause is idiopathic. Manifestations include edema that worsens throughout the day, anorexia, fatigue, abdominal pain, respiratory infection, and increased weight. Their blood pressure typically remains unchanged. They can have diarrhea caused by edema of the bowel. Diagnosis is made by the symptoms and labs. The UA will show 3+ to 4+ protein, and it's dark and frothy. Microscopic hematuria may be present. Cholesterol, triglycerides, hematocrit, and hemoglobin levels are all elevated. Electrolytes are normal, as is that ASO titer. The child with nephrotic syndrome may initially be hospitalized. Prednisone is given to put the child in remission. Remission is considered when there's less than 1+ protein in the urine for 3 to 7 consecutive days. Steroids will be used many times up to 6 weeks. Other management includes a no added salt diet, diuretics, and possibly albumin. With the severe edema, we need to watch for cellulitis and skin breakdown. We need to use good infection control measures as well. Education on the importance of receiving the influenza vaccine and the pneumococcal vaccine. Nursing care includes trying to reduce that skin breakdown by supporting edematous body parts, have them change positions every 2 hours, and the use of non-alcohol-based lotion for dry skin. To help keep hydration levels where they need to be, you're going to monitor their eyes and nose, you're going to monitor their vitals, and monitor for other signs of dehydration. Also need to monitor the excess fluid as evidenced by the edema and decreased excretion of the sodium. You will monitor daily weights, stick to the no added salt to foods, and administer diuretics as ordered. Acute kidney injury, AKI, formerly known as acute renal failure, is a sudden severe loss of kidney function. The kidneys can no longer filter waste products, regulate fluid volume, or maintain chemical balances. Most children who have AKI will regain renal function. One cause in children is dehydration. Manifestations include electrolyte imbalances, fluid volume shifts that could have an increased BUN and creatinine, and acid-base imbalances. Other manifestations can include poor feeding and appetite, vomiting, lethargy, seizures, and pallor. Diagnosis is important so they can treat the underlying cause to help return to full renal function. Diagnosis is made by the history of the illness. Was there any vomiting or diarrhea or fever? They'll look at the fluid volume status. Is the child showing signs of dehydration? It can also occur from fluid volume overload, so assessing lung sounds, looking for edema and hypertension. Metabolic acidosis can occur. Sodium levels can be either increased or decreased depending on if dehydration or the fluid overload. They will also look at the GFR. They will also do a physical exam. Hypertension may be occurring, edema, and decreased urine output as well. They could have respiratory distress if they're experiencing that fluid overload. They may also do a renal ultrasound. Therapeutic management needs to focus on correcting the imbalances of the child experiencing. Correcting the fluid imbalance is one of the most important things that need to be done. Accurate I's and O's is crucial. The child could be on fluid restrictions, which can be challenging as many times they do not understand why they can't have what they want. Offering smaller amounts more frequently can help for some. Electrolyte imbalances need to be corrected as well. Most kids with AKI have high levels of potassium because the kidneys cannot excrete this. Potassium is excreted in the diet, or is restricted in their diet and their IV fluids. They may use gastric suctioning to remove excessive potassium, or they may give Kxalate, which will cause diarrhea and the excretion of the potassium. They may need glucose and insulin. Insulin administered with the glucose will facilitate the uptake of glucose into the cells, which results in that intercellular shift of the potassium. Fluid restriction can help with the hyponatremia. Sodium bicarb may be given to correct acid-base imbalances. Proper nutrition is crucial. The diet needs to be low in sodium and potassium and phosphorus. They need protein for growth. Dialysis may be needed. We'll discuss the different types of dialysis in a few minutes. Most children will be in a special care unit at the hospital. Nursing considerations include monitoring and maintaining proper fluid, electrolyte, and acid-base balance. Prevention of infection must be done. Monitoring and providing adequate nutrition, reducing stress to the child and parents, and teaching about the disease and treatment options. Chronic kidney disease is the irreversible loss of kidney function that usually occurs after months to years of decreased kidney function. It can be managed with proper diet and medications, but will eventually result in end-stage kidney disease. Manifestations for both AKI and CKD include electrolyte and fluid imbalances, acid-base imbalance, anemia, poor growth, hypertension, fatigue, poor feeding, nausea, and vomiting. Neurologic changes can occur from the building up of the waste products in the blood. Lab values will show an increase in the BUN and creatinine. Electrolyte imbalances and high phosphorus are a few labs to consider. Therapeutic management includes monitoring labs and correcting the abnorms. Strict I and O. We're going to provide diuretics and antihypertensive if ordered. Educate on the importance of a child to receive immunizations. Dialysis may be needed with CKD, but it's definitely needed for the end-stage renal disease and consideration for kidney transplant. Dialysis will remove the waste products and excess body fluids and regulates electrolytes and minerals. There are two types of dialysis, hemodialysis and peritoneal dialysis. Hemodialysis cleanses the blood by circulating it through a special filter called an artificial kidney. The blood is pumped through that artificial kidney and returned to the body. This is done by a surgically placed vascular access, such as a central line or an AV fistula. Most children on hemodialysis will have it 3 times a week for 3 to 4 hours each time. Major complications include infection or obstruction at the access site. Also, the child will miss school and the parents' work, so this can cause strain on the family. Hemodialysis is more efficient and takes less time than peritoneal dialysis. It's performed at a dialysis center. Peritoneal dialysis is done by having fluid enter the peritoneal cavity through a catheter that is placed in the child's abdomen at the bedside or operating room. The dialysis fluid remains in the cavity for a prescribed time while waste products, chemicals, and fluid pass through the peritoneal membrane into the fluid. The fluid is then drained out of the body and the process is repeated. For many kids, this process happens every night at home while the child is sleeping. Advantages include more independent for the child and the family and more stable physiological state due to more frequent occurrences of dialysis. Disadvantages include the risk of infection and the stress that the child and family can experience.